We're going to look at the person's unit and bed making today. So when we're looking at the person's unit, it's really important that whether we're working in a hospital or we're working in a nursing home, that we try to keep their environment as clean and as appealing as we can. I mean, for many of these people in the nursing home, this is going to be their home. This may be the last place that they live, and we want it to feel like a home. We don't want it to feel like an institution. So we want it to make it as comfortable for them as we possibly can. Now, when you're looking at, as far as temperature and ventilation goes, OBRA, that Omnibus Reconciliation Act that we talked about, that is really involved, it's a federal law that's involved in making sure nursing home quality is good. They say that temperatures need to be maintained between 71 and 81 degrees. Generally, you're going to find that the nursing homes are fairly warm. When we're in there doing our care, I find that most of my students, they come in there, all dressed up, warm, because it was really cold out, and as soon as they start getting going, making beds, cleaning the patients up, they're starting to peel layers off, because it does feel very warm in the nursing home. They want odors to be minimal. So you have to remember that a lot of reasons why, or one of the main reasons why people end up in a nursing home is because they are incontinent of urine or bowel movement. So, but we don't want it to smell like that. So we always want to make sure we're cleaning people as soon as we possibly can when we know they've been incontinent. And we want to make sure that those soiled briefs, if they're wearing briefs and they have a soiled brief or their soiled linen, that we take it out of the facility right away. So when we take our tour of the facility, we're going to show you that they want you to bag up, any soiled brief, any soiled linen, you bag it up, and you actually take it out of the facility. They have laundry hampers outside of the facility, so that smell doesn't stay in there. Sometimes my students say that nursing homes smell. They notice that nursing homes smell when they first get in there, and then after a while they get used to it, and then they don't notice it. But I really feel that the nursing homes we go to, that we do our clinical rotations at, I think they do an amazing job. Trying to keep it clean and where it doesn't have unusual odors. The other thing is with odors too is we have to remember that these people are going to be eating in there. They're eating in the dining room, or if they're eating in their room, we don't want it to smell, like getting soiled briefs, incontinent linen, anything like that. We have to pay attention to noise. Loud noises can be very irritating to patients. Sometimes patients think staff are talking about them or laughing about them if they hear everybody laughing and talking up at the nurse's station. And especially at night, the volume at nighttime as things just get carried down the hallways is phenomenal. Now, most of the nursing homes we go to, they do not have carpet in the rooms or in the hallways, and that's a cleanliness issue. It's much easier to decontaminate things, to keep things clean if there's no carpet. The flooring cleans off much easier. But with that said, because there's flooring and not as much carpet usually in a nursing home, it means it's noisier. So it's something we have to really be aware of. They recommend, be careful when you're wheeling carts and stuff, especially at night, in the middle of the night. They don't want you wheeling big, heavy carts down the hallways. Your rubber-soled shoes, so they're a little bit quieter when you're walking into a room. As far as lighting goes, brighter lights help with safety, but softer lights are better for promoting relaxation and rest. So depending on what shift you're working, if we're working day shift, we might want the bright lights. If the evening's going on and we're giving care, the bright lights might be okay as well. But then we want to start going over to softer lights to start promoting that relaxation to get them ready for bed. As far as the room furniture and equipment goes, you're going to find that all the beds in the nursing homes are different. In the hospital, they tend to have newer beds, but in the nursing homes, they're older beds, new mattresses, but older beds. So they all work just a little bit differently. The bed controls, you'll find them in different places. The way the safety rails go up, you're going to find that they all work a little bit differently. We do want to make sure that wheels are locked. We don't want to be transferring patients in and out of bed with the wheels unlocked. So usually they lock the wheels, or you're going to find in the nursing home, a lot of times they take the wheels off just so they don't accidentally become unlocked if someone tends to be a high risk for falling. The beds, the wheels should be locked when we're giving care, when we're transferring a person. The bed rails we have to use as directed. So when we talked about restraints, we were talking about how 2 rails were considered a positioning device, 4 rails were considered a restraint. But just this last year, the state law changed that, and they said side rails are basically restraints. Now, so they started taking them off all of the beds. But the problem with that is a lot of the residents really rely on those to help them hang on to it when they're standing up, to grab onto for balance when they're putting their clothes on, for positioning when they're trying to roll on the side. So what we're going to find is that a lot of the residents have signed releases that they can have the 2 upper rails up as positioning devices. But if they haven't signed that release or that consent to have those rails up, then those rails are going to be taken off and all the rails are going to stay down now. As far as bed positionings go, we have learned our bed positionings when we were talking about our module on body mechanics, but supine is lying flat, prone is lying on the stomach, semi-Fowler's, the head of the bed, is usually only up about 30 degrees, Fowler's is usually around 60 degrees, high Fowler's is 75 to 90 degrees. Now the term Trendelenburg is when the whole bed, you can actually raise the whole bed up and tilt the head lower than the feet. Now that is not a position that as a CNA you should be putting your patient in. There are some risks involved in putting a patient into Trendelenburg position. But we do use that position, nursing will use that position, especially if they have a drop in blood pressure, they're going into shock for some reason, they might put them in a Trendelenburg for that. Reverse Trendelenburg, they use sometimes for tests, and they actually tilt the whole bed or the whole gurney up, so they're more in a standing up position. So there are some tests that they like to run where they will do that. As far as bed safety goes, so again, part of our goal is to keep their environment as safe as we possibly can. The term entrapment, entrapment within the bed can happen to our elderly patients when they're frail, they're confused, they're restless, they have poor muscle control, or they're really small, or people that are restrained. When they're restrained, they tend to get tangled up in those restraints and tangled up in bed rails. Patients can get stuck between the rails and the mattresses, or the mattress and the head rail or the foot rail, which is one of the reasons that a lot of those side rails now have been taken off altogether. Call lights need to be in reach at all times, and when we're in a home care setting, they'll usually give them a bell, that they can ring if they need something. Always answer your lights as soon as you possibly can, but we do realize sometimes you're going to be tied up in a procedure and your call light's going to go on. So we also want to help each other answer lights as well. So when you see a call light going on, even if it's not your resident that you're taking care of, if you're not busy, please answer it and see what they need. Now, before you give them something to drink, before you get them up and move them, we do want to check with the regular staff and make sure it's okay, that they're not on fluid restrictions, that they're not on thickened liquids, that it's okay for them to get up and then get out of bed. But otherwise, we can help people even if they're not our patients. We just want to make sure that whatever they're asking for, it's safe for us to do it. Now, a lot of the residents will have tab alarms, and tab alarms can be put on a bed or it can be put on a wheelchair, and those are for people that are high-risk falls. And I know we've already talked about tab alarms when we were talking about safety issues, but when a person's a high-risk fall and they have a tab alarm, and they try to climb out of bed or they try to get out of their wheelchair, if you hear that tab alarm go off, please go check on them. It means a high fall risk patient is trying to climb out of bed or trying to get out of their wheelchair without help. Very, very dangerous. Don't go looking around for a regular staff member. Go check on them, make sure, so we can actually help, remind them to get back in bed, or remind them not to get out of to get out of bed without help, so they don't fall and so they don't get hurt. This is what entrapment looks like, and again, this is one of the reasons why side rails have become kind of a no-no, even the upper rails. But I've never seen this where someone's gotten stuck in the middle of the rail, and I haven't seen this one either. I have seen this, and I have seen this, and this one down here. But these are just some of the entrapment areas that can happen when patients are older, when they're frail, when they're confused, and they're not really sure, what they're doing. Now, a bariatric bed is an extra large bed. It's extra weight capacity, it's extra wide, and they make extra wide beds, which are the bariatric beds. They also have extra long beds for people that are really tall. So if you have a patient and they're not fitting properly in the bed, we can always get something like that ordered for them. Now, as far as room furniture and equipment in the patient's room, generally what you're going to see is you're going to see a dresser over by the bedside. So everyone will have a bed and they'll have a dresser by the bed. And usually what you're going to find in here is in the top drawer you'll find personal care items, hairbrush, dentures, hearing aids, things like that will be in this top drawer here. In this middle section right here is usually the bath basin, things that we would need to get them cleaned up. And in the lower one, we put the bedpans, urinals, things like that would go in the lower drawer. And then if it happens to have shelves on it, they can have their own personal knickknacks. They will also have a bedside table in their room, and they also will have a closet and a chair so visitors can come and see them. Privacy curtains, all the rooms will have privacy curtains in them, and we do need to remember that we need to pull the privacy curtains all the way around and just kind of look around that room and make sure we got everything all covered up before we're giving care. Closet space, as I mentioned, they only get one closet, so they've got one dresser and one closet. They really don't have a lot of room in these rooms. Now, some of the newer nursing homes, they kept that in mind when they were building them, and they built extra closet space, extra drawer space. But a lot of the older ones that we go to for our clinical time, it's going to be very crowded, and a lot of these people have a lot of personal belongings that they want in there. And we want them to have their own personal belongings. We want it to feel like a home for them. But again, we have to be careful with that. And then every patient has a call light. So some basic rules is arrange the items the way the person wants them. So how do they want them arranged? What are their wishes? Don't throw anything away without checking with them. We had a lady at one of the facilities we go to, and she had a Victoria's Secret bag that she used to put her own personal soaps and lotions in when we were taking her down to the shower. And she loved that little Victoria's Secret bag. It was just like the bags that they get when you go shopping at Victoria's Secret. They give you a bag and it says Victoria's Secret on it. Well, I guess it had gotten stuck when she came back from her shower and she'd stuck it over to the side. It must have gotten caught up in some of her newspapers, and when the housekeeper came in and was clearing out her room, she threw all the newspapers away. It was in there. She was so distraught. We looked for hours for this Victoria's Secret bag. It was so sad. And there are things that we might not think of it as being something that it's really important, or we might think of something that, oh, this is just an old bag, it's time to throw it away. But always ask before you toss anything at the patient. We've talked about not taking patients' belongings. Obviously, that is a form of abuse, to take their personal belongings, their personal possessions, use their money, anything like that. So don't take their belongings. And if family members do take their belongings home, try to remember to document that. So when a person gets admitted to a facility, we do a belongings list. We make a list of everything they're going to keep at that facility, so when we send them home, we can compare and make sure we're sending everything home with them. Well, if the family took something home after a month, and then the next month the patient's going home, and we're getting that belonging list, and now we're looking for that item that they took home, and the patient may not remember it, the family member might not remember it, might be a different family member who's there when they're getting ready to go home, and then you spend hours looking for something that was taken home. So when a family member takes something home, make sure you make a notation of it on that belongings list. Keep the person's room neat and clean. Okay, we want to keep it as sanitary as possible. We want the housekeepers will come in every day and clean the rooms, and then usually once a month the rooms are deep cleaned, where the patient comes out of it and everything, the curtains are washed, everything in the beds, the mattresses, everything is scrubbed down in that room. So they do that usually once a month, but every day they come in and clean the bathrooms and clean the bedrooms up. But in between then, we need to make sure we're cleaning up afterwards as well. If there's a spill on the floor, wipe it up, okay? If there's something that you think it not only needs to be wiped up, it needs to be decontaminated, you can go get the housekeeping for that and ask them to decontaminate it. Personal care items should always be labeled. We do not share personal care items between residents. We don't share their bath basins. We don't share their bedpans. We don't share the graduated cylinders. Okay, every item that you use for that resident should be labeled with their name on it, and we don't use it for another person. So I always recommend to my students to bring a black Sharpie as part of your uniform. Get a black Sharpie and keep it in your pocket. That way when you get a new item out, you're not looking for a label. You can just write their name on it and their room number, and you're good to go. We do not store personal care items in the bathrooms. So unless it's a private room, if you have a private room with a private bath, then it's okay to keep their personal care items in the bathroom. But generally, in most of the nursing homes, they have like Jack and Jill bathrooms where, both sides of the bathroom is being used by different people. And so you always want to make sure that there's nothing stored. Even if it's labeled, we don't store it in the bathroom because some of these residents don't necessarily read the names on things. They may just accidentally pick up the wrong person's toothbrush, hairbrush, that type of stuff. And any time before you walk out of a room, always do a safety check of that room. Always make sure that the bed's in low position, the call light's in reach, no clutter laying around that people could trip on. The things that they normally want to use a lot, the things that they reach for a lot are within easy reach. Just always make sure that we do a safety check before we walk out of that room. So bathrooms, like I said, are generally shared. Keep them clean. Clean up after your resident. If they have an accident and they don't make it quite to the toilet, wipe up everything, clean it down, and then again, you can get housekeeping to help you get it disinfected properly. Supplies should not be stored in shared spaces. We already talked about labeling the supplies. We place supplies on a towel, not on the counter, because they are shared bathrooms. So you don't want to put the toothbrush directly on the counter sink. You want to make sure you put a towel or put a couple paper towels down and put the supplies on that. So don't put things directly on the counters. They're not considered clean since they're shared between multiple people. There are call lights in the bathrooms, and so in the nursing home, you're going to find that when a person puts their call light on, it shines a light right outside the door, and it'll just, it'll beep at the nurse's station. So there will be a light that shines at the nurse's station, so you know what room it is that's calling for you, and it'll beep at you. It'll keep beeping at you, and the light is up right outside their doorway. When a person's in a bathroom, the call light that's in the bathroom will also shine right outside the doorway, but it'll start flashing. It'll flash. And that lets you know someone's in the bathroom. And so, try to make sure you're responding to those lights right away. As far as bed making goes, you notice how this person is carrying the linens. You want to carry the linens away from your uniform. We want to use medical asepsis, clean technique. Okay, your uniform is considered dirty, so we don't want to carry things right up against our uniform. So when we're collecting linens, I collect them in the order of how I'm going to use them. So I grab my bottom sheet first, draw sheet if I'm going to use one, or waterproof pad, then the top sheet, then the bedspread, and then their pillowcases. And then I carry them into the room and I flip it over onto, I've already hopefully cleaned off a workspace, okay, and then I'm going to flip it over so they're right there in the order of how I want them. If you just grab all of the linens at haphazardly, and then you're going through and now I want to pull this one out first right here in the middle, there's a good chance I'll knock all the other stuff off onto the floor. And if something hits the floor, it is considered dirty. There is no 5-second rule in nursing. Hey, I had 2 kids. I remember first kid dropped a pacifier. I would wash it with soap and water. I'd rinse it. I'd sanitize it. I'd boil it in water for 5 to 10 minutes before I'd give it back to her. Second one, it looks good. Wipe it off on my jeans and here you go. There's no 5-second rule in nursing, ever. Something hits the floor, it's contaminated. We get rid of it. It's going to go in that soiled linen hamper. You're going to need to go out and get something else. Also remember when you're getting linens in the linen cart, you are not allowed to wear gloves in the hallways. You do not wear gloves in the hallway, and you do not wear gloves in the linen cart. So carry them away from you. Don't hold them against your uniform. Place them on a clean work surface when we're getting ready to make the bed. Now, when we're taking off the old sheets, when we're taking off the dirty linens, we remove one piece of linen at a time, and we're wearing gloves. Anytime you're dealing with dirty linens, you're going to be wearing gloves. So one piece of linen at a time, you roll it away from you, and you're going to set it aside, and then we'll take all that dirty linen and put it in the soiled linen hamper. Some places that you'll work as a nursing assistant, they will have bags. They'll have like big linen bags, and you just grab a linen bag and you just put your soil. You're not ever allowed to throw dirty linens on the floor. Never ever throw stuff on the floor. Things do not get stored on the floor. But if you are if you have a linen bag and you put your dirty linens directly into the linen bag can be set on the floor. And then when you're all done with your room, you can just carry it out and take it out to the dirty linen carts. So we wear gloves on, we remove one piece at a time. I always try to tell my students, when you're stripping a bed and there's no patient in it, it's easy to just take off one piece at a time and throw it into that bag, into the linen hamper. It makes it easier for the next person down the line. When laundry goes through to start sorting the linen out, if it's all in one big blob, they've got to pull it all apart and then sort it. If it's already just one piece at a time, it's easier for them. So when I do an occupied bed change is where you make the bed when the person's in it, so you're dealing with all their dirty linen and their clean linen all at the same time. When we're doing that, all the linen tends to come off in one big blob. I am not going to take my time as a nurse to sit there and sort it through. It will actually be more cost effective for the housekeeping, for the laundry services to do that. But if the person's not in bed and I can make it easier for the next person down the road and it's not going to take me any more time to do it, then that's how I should be doing it. So we're wearing our gloves when we're touching the dirty linen. When we're putting clean linens on the bed, we do not need to be wearing gloves for that, but when we're doing the dirty linens, we do. So remember good body mechanics. When we're changing beds, we want to use good body mechanics. Bring that bed up to a good working height so we're not bending over. Medical asepsis, clean technique. We don't shake linens out. You unfold linens. You don't shake things. Okay, that's any bacteria or viruses that are trapped in the dirt or gets spewed up in the air particles. So we don't want to shake things out. Don't touch our uniform with the linens. Wear gloves when we're removing the old stuff. Don't put it on the floor. And remember privacy when we're removing linens. And the only reason I'm going to say that's an important piece is especially if they've been incontinent. So if they're incontinent and they're soiling on the linens, you don't want other people to see that as they're walking by or other people in the room to be noticing that. So we can pull the privacy curtain if the linens are dirty like that. Types of beds that we would make is there's a closed bed when the patient is going to be out of bed all day long. We actually pull the sheets and the blankets and the bedspread up. Everything's pulled up nice and neat, and it encourages people not to crawl back into bed. And remember, if these people are living there, we really want them to get involved, have a sense of community, get involved in activities, so we can do closed beds. An open bed is when our patient gets out of bed, we change all the sheets and stuff, but we're expecting the person to get right back into bed. So after we make the bed, we take those top sheets and blankets and we fan fold them back so it's easier for the patient to get in bed, and then they can just pull them right up over them. And an occupied bed, which I'll be showing you a video of how to do an occupied bed, the person's in bed while we're changing the sheets, and this is a little bit more of a process. It is easier to do an occupied bed change with two people, but you can do it by yourself if the person can follow directions and if they can move okay. If they can't move okay and they can't follow directions, you are definitely going to need a second person to help you with an occupied bed change. So this here is a closed bed where everything's, the bedspread's all pulled up and nice and neat. And at some facilities, they'll even tuck the sides in. Now, when we were talking about restraints, we told you if you tuck the sheets and the blankets in really tight on the sides, it can act as a restraint. That's if the person's in the bed. If you have a person in the bed, you never tuck the side sheets in. But if the person's out of bed and they're not going to be in bed all day, you can leave the sheets like this. Or when you lower the bed all the way to the floor, if these sheets or blankets are going to hit the floor, because some of the beds in the nursing homes go really, really low, then you can actually tuck them in the sides. This is the open bed. So if we're expecting the person to get right back into bed after we make it, we'll leave it, we'll fan fold these back. They can get in bed, and then they can pull the covers up. Now, this is a draw sheet, and draw sheets usually go from shoulder to mid-thigh. And so if you have a person who's heavy, who doesn't move around very well, we put a draw sheet under them. And if they don't have a true draw sheet at the facility where you work, you can actually take a top sheet, fold it in half, and use that as a draw sheet. But what we do is we roll those draw sheets up nice and close to the person, and then we have something to help us lift the person up so we're not just dragging them up on the bed, so we aren't causing friction and shearing with them. So we can actually roll them up and lift them up in bed. This is a surgical bed if a person's coming by gurney. So if the person is coming by gurney, then we're going to be sliding them over to the bed. They fan fold the sheets over to the side like this. So we don't generally see that in a nursing home setting, but in a hospital you might. And we will stop there.